We've heard a lot about Chiari malformation and Chiari-related syringomyelia, but as many of you know, syringomyelia can exist in the absence of Chiari malformation. And depending on the type of practice that the individual clinician has, one or the other may predominate. In my own experience, I actually started off with focusing on what was then called spinal syringomyelia. We now use the word primary spinal syringomyelia to distinguish this kind of syringomyelia from the Chiari-related type. I want to talk very briefly about pathophysiology, and my comments have been made a lot more understandable in light of what you've heard before. But as you've already heard, CSF pulsates at all times, 24 hours a day, synchronously with pulse, and it also fluctuates with respiration. And so when the spinal fluid encounters a partial obstruction, it becomes easier, and this is a very simplistic way of speaking about it, it becomes easier for the spinal fluid to enter into the spinal cord than to travel along the outer surface. And as a result, fluid accumulates within the spinal cord in that way. Now, this sort of partial obstruction of the spinal fluid space around the spinal cord can occur from spinal cord injury, as you see here. It can occur after meningitis, after hemorrhage into the subarachnoid space, or sometimes when some foreign material has been introduced into the spinal fluid. Bone fragments from an injury or a deformity, a severe deformity of the spine can do it. Very rarely, a large disc herniation can do it. An arachnoid cyst can develop primarily because in the development of the linings and coverings of the spinal cord and brain, there's an extra little web that can act as an obstruction to the spinal fluid circulation. And finally, tumors of the spinal cord can do this in a way which I'll allude to briefly to come. Tumors can be associated with a true cyst, and some of you may know that brain tumors can be associated with a cyst, so can spinal cord tumors. And the cyst that is associated with a tumor very often it has a high protein content. If you were to drain it, it is yellowish in appearance. And it really is a tumor cyst and not a true syrinx in my terminology. On the other hand, if the tumor is large enough so that it can press against the bony walls of the spinal canal, it can create this situation of having a partial obstruction of the cerebrospinal fluid space and cause a true syrinx to form. So, in a way, syringomyelia is a symptom of subarachnoid stenosis or narrowing of the spinal fluid space, and the treatment must be directed at eliminating this partial obstruction whenever possible. The diagnosis is made either with MR scanning, but occasionally, and we've heard this already, a brief allusion by Dr. Linetsky, contrast is needed, and in the area of the spine, myelography still has a significant role to play in showing us the partial obstruction in some instances. It may be helpful in defining the surgical strategy, and particularly is this true when you have a syrinx cavity in which the abnormality, that is to say, the source of the partial flow obstruction, is not evident on the MR scan. Sometimes there's just a diffuse honeycombed syrinx. Sometimes we think by the appearance of the contour of the spinal cord that there must be a sudden block, or partial block more accurately, to the flow of spinal fluid. And the myelography may also help us to define the exact limits of the bone removal that we have to perform in order to deal with this problem. Now, Like everything else, there are limitations to even the most advanced technology, MR scanning, that we've heard about. And so myelography, for that reason, still has a role to play. Sometimes it's difficult for the MR scan to be in the exact plane of the obstruction, and it is easily missed. And it is also more difficult to define the upper and lower limits of the obstruction in that way. I like particularly to perform, or have the radiologist more accurately, people like Dr. Linetsky, perform the myelogram at the upper cervical region for a good reason. One is that sometimes the obstruction or partial obstruction to the spinal fluid circulation that I've alluded to has a one-way valve effect, and so if you introduce the contrast in the lumbar region, as is most commonly done, the contrast may flow by, whereas it hangs up if it's introduced from above. The other benefit of doing it from above is that people who have the spinal fluid puncture at C12 do not develop a post-lumbar puncture headache for obvious reasons. Now, let me talk first about post-traumatic syringomyelia, or as it's sometimes called, post-traumatic spinal cord cavitation. And the treatment options in the broadest sense are resection of the scar or web. Sometimes I've performed an expansile duroplasty when I could not resect the scar or web. And rarely we have had to perform a shunt, either from the syrinx cavity itself or from the spinal fluid space around the syrinx cavity. Now, there are some practical and interesting aspects to post-traumatic spinal cord cavitation. The trauma may have been trivial because all that is necessary to set the stage for a partial obstruction of the subarachnoid space to take place is for some little bit of blood to escape into the spinal fluid and set up a scar, or some other mechanism, stretching of tissues to set up scar, which can then delay the flow of spinal fluid along the outer surface of the cord. The other thing is that for reasons which are not clearly understood, there may be a delay between the injury and the development of the syrinx, or let's say the symptomatic appearance of the syrinx, so much so that sometimes the patient has even forgotten what the actual situation was that might have started the process of developing scar tissue. And the other, from a practical clinical point of view, is that patients may go along, have some vague symptoms until they have some upper respiratory infection or for some other reason cough. And with a severe cough, there may be a sudden development or ascent of symptoms in the patient. This is just an illustration from one of Dr. Millerat's papers, which shows, I don't think this pointer is working very well, but it's a nice idea, but I don't think it works. There we are. Okay. It is a nice idea, and it works. But one of the things to remember about a post-traumatic syrinx cavity from the treatment point of view is that the syrinx cavity, which you see here, may actually break through the linings of the spinal cord, which has some direct implications for treatment as well. This is from an old paper by Dr. Barnett, and the kind of symptoms that he saw in patients with post-traumatic syringomyelia are those that you see here. Interesting aspect is the incidence of spinal cord syrinx, primary spinal syringomyelia, over the years as our diagnostic abilities have improved. Used to be said to be around 3%, then 17, now with MR, at least 22%. And the question arises, well, why only 22%? Why is it, in fact, that only, depending on your clinical experience, 50 or 60% of patients with Chiari malformation develop syringomyelia? And one of the theories that has been proposed is that if a patient still has a persistence of the central canal, which is something that we are all born with and all have in utero, but it usually disappears as we get older, but not always. And if the central canal persists, this is the central canal of the spinal cord seen in the histological section of the cord. If it persists, is that patient then more likely to develop syringomyelia? This is a paper from Yasui in Japan and shows how the central canal disappears with age, but having got there, there is still a small number of patients with a patent or visible central canal in the over 100-year-old group. In most patients, in most individuals, the central canal disappears by age 10 or 20. So it's an intriguing idea to think about that. This is such an image of the residual central canal, and Dr. Linetsky already spoke about it, but classically it is fusiform in appearance, and if you look very carefully, there's actually a linear extension above and below, and here's one that's in the lower spinal cord region, same kind of appearance, and typically they're like a bullseye in the center of the cord and round. And I can tell you that in my own practice, I've seen several hundred of these because patients have an MR scan done for some other reason, and unfortunately radiologists will use the term syringomyelia for these, and the patients then get onto the computer, read up about it, and are very worried about the clinical implications. When I see patients like this and they have symptoms, I look for other causes of symptoms because these things, in my opinion, are totally asymptomatic. So it is important, I think, to distinguish these, and I would prefer to use the term hydromyelia for the residual central canal as against syringomyelia, which is a pathological condition with a distended cavity, often, as you've already seen before, eccentric and irregular, whereas hydromyelia is a benign remnant of the central canal and really does not warrant any surgical or other treatment. Now, focusing a little bit on the subject of post-traumatic syringomyelia, it can exist both with and without bone deformity. And in looking at in assessing a patient with post-traumatic syringomyelia, it's important to find out the degree of subarachnoid stenosis. Is it complete or incomplete? The extent, is it extend over several vertebral segments? And is it in the high cervical region, or is it in the mid-cervical or thoracic region? We're going to talk first about bone deformity producing this compression, which may be both anterior and oftentimes also posterior. Here is an artist's conception of an anterior impression from an injury of the neck. And here, the injury has been corrected, and the syrinx cavity, which is distended in this image right here, collapses when this partial obstruction of the subarachnoid space has been eliminated. And here is a clinical example. Before surgery, you see the large distended syrinx cavity extending all the way up here. By the way, the cerebellar tonsils are normal in position. And here, the syrinx hasn't disappeared, but it is smaller, and I would argue that this case, which was treated many years ago, there might still be some scar tissue in the subarachnoid space around here. This is a second case where the syrinx is in the lower thoracolumbar region. Here you see the dark line of the syrinx cavity, and here's the level of injury. This syrinx extended over time into the cervical region, all the way up. Here it is after correction, and while you still see a little bit of it, the syrinx cavity is certainly smaller, and so it was also in the cervical region. We also see patients who have an incomplete block, or in fact don't have a true block on imaging studies, but have a syrinx. And for those patients, shunting may be the only available option. And here is a case like this, again, studied not with myelography at the time, but you can see This patient had some posterior instrumentation which sort of deteriorates the image, but you can see the syrinx cavity in the cervical region extending there. And in this patient, a shunt was placed, and the syrinx cavity collapsed with this maneuver. Now, we also see evidence of post-traumatic arachnoid scarring without any such obvious deformity. And here is a patient of this sort with a syrinx cavity. It wasn't quite clear where the scar was. And so we did a CT myelogram on this patient, and it's very obvious that there's something happening right here. And in this particular patient, we actually aspirated some fluid from the cord in order to get the process started and sewed in a dural graft. Here is another one. No, this is the same one, and I will remind you, just in case. No. This is what it looked like before. This is what it looks like now. In patients who have a very high cervical injury, we don't want to manipulate the spinal cord in the high cervical region because the innervation to the diaphragm and therefore respiratory control is sometimes jeopardized by manipulating the cord in this high cervical region. And so here is an example of that. And you can see the area of injury right here at about, this is C2, 3, 4, 5, 6. Here's an even more dramatic one at the C2, 3 level. And some folks both from Greece and from India described shunting fluid from the subarachnoid space rostral to the obstruction, namely up here, into some other compartment like the abdomen. Dr. Sandy Lamb, who was with us at the time, is Dr. Lamb here yet? No, she'll be, there she is in the back. Okay, she'll be speaking to us later. Helped us develop this, and the idea is that if you consider that this fluid up here pulsates all the time with respiration and heartbeat, if you can dampen these pulsations by draining fluid off to some other part of the body, you reduce the filling tendency of this cavity. And although in this particular patient in whom we did this operation, the only difference that it made was that he was able to use his fingers to manipulate his mobile mechanized wheelchair, that was a big difference for that particular patient. This is the Thecoperitoneal Shunt, and I've just explained the theory, and I'll skip over this. This is just an artist's illustration of how this works. And so we always use at least a myelogram to make sure that there is no way that the fluid can go by. This is an example of a lower spinal cord syrinx which formed in a patient who had undergone surgery for a spinal cord tumor. This is a true syrinx, and we did a subarachnoid shunt rostral to that cavity, and the syrinx, as you see, is considerably smaller. Now, I want to talk about a different mechanism, not post-traumatic, but congenital arachnoid cysts and diverticuli, which can produce, by the same mechanism of partial obstruction of the subarachnoid space, syringomyelia. Here is such a patient. Again, we see a typical syrinx cavity, but we didn't know where it was coming from. It's eccentric, making this certainly very different from the residual central canal. And here we did a myelogram, both from above and from below, as I've mentioned before, and you can see the block here and the block there. Intraoperatively, I like to inject indigo carmine to help me identify where the block is, and you can see very clearly that there's some obstruction to the flow of fluid right at this level. This happens to be from another patient, but it also shows how scar tissue or a web can form and obviously impair the flow of cerebrospinal fluid. And postoperatively, this patient had subtotal resolution of syrinx cavity, but clinically was much better. And you remember there was a little hole right here. That's gone completely. This is another patient, slightly different, as you'll see in a moment. Here's the syrinx cavity. And here we see a very typical abrupt change in the caliber of the cord. Here's the distended cord with the syrinx cavity. All of a sudden, at this level, the cord became normal. Dr. Holly and I actually, no, I'm not sure. Yeah, I think we operated on this patient together. And at T7, we found an unusual constellation of things, a sac of arachnoid that had formed in such a way as to be able to compress the spinal cord and obstruct the circulation of CSF and result in a syrinx cavity. And when this was filled with indigo carmine, here you see it, when it was resolved and resected, the syrinx went away. So I want to talk briefly about syringomyelia, which can develop as a delayed sequel to tumor removal. I already showed you one patient who was treated by another neurosurgeon. Here's one who had a syrinx for many years after removal of a spinal cord tumor, which was a benign tumor. And when we went in there, we found this very, very dense scar in the area of the tumor resection, which was the obvious cause for her developing a syrinx. Sometimes we have patients following an injury, and particularly patients who develop syringomyelia after meningitis or subarachnoid hemorrhage, who have a scarring of the subarachnoid space that extends over so many vertebral levels that resecting that scar is just not possible, or it would be associated with great risk to spinal cord function. And here is such a case. This is a woman who had meningitis and developed this very extensive and somewhat irregular syrinx cavity. And so shunting is one of the options that we have for this. This is a shunt that we like to use with a smaller tip at the end and multiple holes. And here you see it in place in the artist's drawing. And the problem with syrinx shunting is that while it's very good, in certain cases it is subject to acute and delayed complications, including scar formation and obstruction of the syrinx, of the catheter rather. And so shunting should be considered only as a last resort when no other options are available. In our own experience, we had 18 patients who developed shunt obstruction, 3 with tethering, 1 with infection. Low CSF pressure can result, and one patient who had this low pressure syndrome actually died. People can develop problems at the far end of the catheter. If it's implanted into the abdominal cavity, they can form a cyst around it, particularly if there's a low-grade skin contaminant infection. The catheter can become dislocated, and other things can occur too more rarely. This is a problem that is inherent in shunting a syrinx cavity. The spinal cord, when successfully shunted, may collapse around the catheter, and if it does so, it will actually stimulate to some degree ingrowth of normal tissue cells into the catheter. But if that is possible, then the shunt will cease functioning. And we've recently developed a different type of shunt that may prevent this from happening. Poor shunt placement. This particular patient had a shunt placed in this part of the cavity, but it had a double chamber and one cavity was not implanted. The shunt may become tethered, as in this particular situation. Infection can occur, as occurred here, a small, tiny abscess. Low CSF pressure state, we've already heard about the highlighting of the meninges with low CSF pressure. And lastly, neurologic deficit can occur just from placement of the shunt because one has to make a small incision into the spinal cord. It is therefore preferable to do as little of bone removal to place the shunt because you want to expose as little of the spinal cord. You also want to remove as little bone because patients with syringomyelia have an increased tendency to develop spine deformity. And so the Japanese colleagues described using a partial hemilaminectomy and placing the distal shunt tube into the subarachnoid space provided it is open. And here is just an example to illustrate how the spine can become deformed when the back elements, the bony elements, the laminae have been removed, and so you want to limit that kind of removal. As I've already said, when there's no alternative to shunting, syrinx to subarachnoid shunts are preferable, and I won't belabor that point. Problems that we've had after any type of shunting: syrinx to peritoneal shunt, syrinx to pleural shunt, subarachnoid decompression, even with a syrinx to subarachnoid shunt, and one patient who had an in-valve placement. So many patients who have shunting procedures have had multiple operations, and this again is true even when we haven't placed a shunt but treated the dural obstruction, the subarachnoid obstruction with a bypass. It doesn't always work, and cyst wall resection is ideal if the cyst is small. I think I will just illustrate this, that the most common reason for shunting is trauma in our experience, but that also includes the largest number of patients who required reoperation. When there's an arachnoid cyst, the numbers are relatively small, but the outcome is much, much better. And I've already indicated that this need for reoperation may occur with any kind of procedure that is performed. Overall, we had about a third of patients stabilized, about 15% improved. Somewhat more than a third required reoperation. Just a word about the term idiopathic syringomyelia, which you will see in the literature and reference made there too, but generally just referred to the types of syringomyelia in which we did not know the cause, but as our diagnostic abilities have improved, the number of patients who really have syringomyelia of totally unknown cause is minimal. So in conclusion, spinal syringomyelia may complicate spinal cord injury, meningitis, subarachnoid hemorrhage. It's important to establish the extent and level of the subarachnoid block, and patients with spinal syringomyelia may require multiple procedures to stabilize their condition, but the outcome is better in patients who have a very focal scar or arachnoid band. Shunting is appropriate when there's no alternative, and an extensive laminectomy is to be avoided because it may lead to spinal deformity. As you also heard from Dr. Heiss just before, early diagnosis and early treatment tends to lead to better outcome. How can we improve treatment? By looking at our failures and not necessarily at our good outcomes. Pain control, important aspect of this. The hope is that stem cells, maybe molecular biology, as well as pharmacology, will help in this area. In the future, very important, I think, for us as an organization to support attempts to reduce the incidence of spinal cord injury, whether that be by drunken driving or anything else that may lead to unnecessary injuries to the spinal cord. There's a lot of effort today at minimizing the effects of spinal cord injury with various chemical interventions, some of them in the field by the ambulance drivers. There's a possibility that we may be able to control scar tissue formation, and certainly there's a genetic element to the tendency to develop scar tissue. And neural repair, stem cells, remains a question. Thank you very much.